Hello and welcome to Preventing Liver Cancer, the fifth seminar of our series, Screenings That Save. I would now request Dr. Ravina Agarwal, Director, Columbia Global Centers, Mumbai, to please begin the session. Dr. Agarwal.
Hello, everybody. I'm Ravina Agarwal, Director of Columbia Global Centers, Mumbai, and I welcome you all to today's panel discussion, Preventing Liver Cancer. It's the fifth webinar of our series, Screenings That Save, and it's a seminar series that was developed in partnership with the Herbert Irving Comprehensive Cancer Center of Columbia University. The center in Mumbai is one of 9 global centers of the university, which has a mission for promoting knowledge exchange, advancing research and education to solve some of the largest challenges that confront us in the world today. The liver is the largest organ in the abdominal cavity and the most complex. It performs a variety of functions, including the removal of endogenous and exogenous materials from the blood, complex metabolic processes, and some major immune functions. The burden of hepatocellular carcinoma is highest in East Asia and Africa, although its incidence and mortality are rapidly rising in the US and in Europe. In India, it ranks 10th among fatal malignancies. Patients are often diagnosed with liver cancer in advanced stages, contributing to its poor prognosis. The worldwide incidence of liver cancer is heterogeneous because of the variable prevalence of underlying risk factors, whether hepatitis B and C infections, alcohol, inherited liver diseases, and so on, which contribute to the burden of liver cancer. Despite the presence, for example, of hepatitis B, vaccines that are available worldwide, this remains the leading cause of incident cases of liver cancer and deaths in the world. Thus, prevention and control of liver cancer holds the key to reducing the overall cancer burden globally. And this becomes even more important because this condition is largely preventable and can be cured if diagnosed in the early stages. In today's webinar, our distinguished speakers will discuss and analyze the global liver cancer burden and elucidate effective and targeted prevention strategies to control liver cancer in India and the world. I turn this over to my colleague, Manisha Pathak, who has helped organize the panel, to introduce our wonderful speakers. Over to you, Manisha.
Thank you, Dr. Agarwal. Our first speaker for the day is Professor Regina Santella, who is currently the Professor of Environmental Health Sciences at the Mailman School of Public Health at Columbia University. Professor Santella's research is focused on the use of biomarkers of exposure and genetic susceptibility to understand risk for cancer development, concentrating on liver and breast cancer. Her laboratory has developed antibodies and immunoassays to several carcinogen, DNA, and protein adducts and uses these methods to determine exposure to environmental carcinogens. More recently, her laboratory is investigating the use of epigenetic markers, including DNA methylation and microRNA expression, to identify those at increased risk or as early biomarkers of the disease. Welcome, Professor Santella.
Okay, so what I'm going to tell you very briefly is a little bit about the epidemiology, the risk factors, and prevention of hepatocellular cancer. This figure illustrates how important liver cancer is in the world. You can see among males, it is the 5th leading in terms of incidence. In females, it doesn't rank among the top 10 in incidence. However, if you look at mortality in males, it is ranks number 2 right after lung cancer. And then in females, because of its high mortality rate, you can see that liver cancer actually comes up among the top 10 in terms of sites for liver cancer, for cancer mortality. So globally, it's a big problem. So this is showing you the trends for liver cancer in the US. So you can see from the 1970s on how liver cancer was dramatically increasing over the years. It may be plateauing more recently, but we're not absolutely sure. You can also see that in the US, there are big differences in liver cancer incidence rates by race ethnicity. So for example, among non-Hispanic whites, there's about 7 per 100,000, while you can see that Blacks and particularly American Indian and Alaska Natives have these very, very high rates of liver cancer incidence. So big race ethnic differences. I tried to find some data on incidence of liver cancer in India, and it looks like it's very variable in terms of the different states in India. Seems to be a little bit lower than in the US. The same differences in males being at higher risk than females, as we see in the US and in the rest of the world. There's a little bit of conflicting data in the two recent papers that I looked at in terms of etiology of liver cancer in India. So as mentioned already, hepatitis B virus is a major risk factor, and hepatitis C virus is also important. But another publication indicated the importance, the increasing importance of non-alcoholic fatty liver disease. Obviously, these numbers add up to more than 100%. And so probably over time, as the incidence related to viral infections decreases and worldwide obesity increases, that we'll be seeing an increase in the importance of non-alcoholic fatty liver disease as a cause of liver cancer. So this slide summarizes the risk factors for liver cancer. So as for all cancers, the older you get, the higher the risk. Male sex is a risk factor, and I've shown you race ethnicity. Having liver cirrhosis of any etiology, whether it's from virus or from alcohol, is a risk factor. We've mentioned virus, alcohol was mentioned. The characteristics of metabolic syndrome, so having diabetes, being obese, non-alcoholic fatty liver disease, these are all major risk factors for the development of liver cancer. And you can see that about 25% of the global population has fatty liver. So we do have a major global problem. I've concentrated on environmental risk factors. Aflatoxin B1 is now well established. I'll just show you one example of data on that. It's a compound that is produced by a mold that grows on corn and peanuts and is a major risk factor still in certain parts of the world. Tobacco smoke is known to be a risk factor. A class of compounds called polycyclic aromatic hydrocarbons, which occur in the burning of any kind of organic material, cigarette smoke, car exhaust, your charcoal broiled hamburger or steak. Vinyl chloride was identified through the occupational setting as a liver carcinogen. And then arsenic is a major problem in terms of exposure in large parts of the world. So those are all environmental factors that impact liver cancer risk. There are certain dietary factors that have been suggested to be preventive. You have to be really careful looking at dietary nutritional data and cancer because it's very difficult to get accurate information and do good studies. There has been a suggestion that coffee consumption leads to slightly decreased liver cancer incidence, and that the intake of whole grains and dietary fiber is also of benefit. I want to just give you one example of how we identify environmental risk factors for liver cancer in particular, but cancers in general. And it is through doing what we call prospective studies. So we collaborated with an epidemiologist in Taiwan who recruited healthy subjects. So these were healthy people. 25,000 subjects were recruited in the early 1990s. And then they followed them over the subsequent years to see who developed liver cancer and who didn't. The advantage of doing these prospective studies is that you collect your samples, in this case, blood and urine, when people are healthy. And so the disease is not going to impact anything that you measure in the urine, but you're going to be able to measure things that would predict later development of disease. And so in that cohort, they sent to us urine and plasma from people who went on to develop liver cancer and people who did not. And we used our immunoassays to measure urinary metabolites of aflatoxin, this mold contaminant that is a factor in diet. And also the aflatoxin can actually bind to the albumin circulating in blood. And so looking at these two biomarkers of aflatoxin exposure, you can see in this bar graph on the left, we also measured hepatitis B surface antigen, which is a marker of active infection with the virus. And in those individuals who did not have viral infection, you can see how the risk of liver cancer went up. So those numbers are the risk of developing cancer if you had the exposure. So if you had high exposure to aflatoxin, but were not virus infected, you had 2.4 times the risk of developing liver cancer compared to someone who was not exposed to aflatoxin and was not a carrier of the virus. You can see the big jump when you look at individuals who are hepatitis B virus positive, because the virus is a major risk factor. But you can also see in the presence of the virus, you can still see the effect of the aflatoxin exposure. So those unfortunate individuals who have viral infection plus aflatoxin, high aflatoxin exposure, have 13 times higher risk of developing liver cancer than those individuals who are lacking in both. So this is the use of a prospective study, collecting samples when people were healthy and looking at how it predicts risk for them developing cancer. We did the same thing for polycyclic aromatic hydrocarbons, PAHs, and you can see very similar data. Here we only divided it into low and high groups for the exposure to the carcinogen. But again, you can see that the exposure in the absence of virus increases risk. In this case, it's about twofold increase in risk. The exposure to the virus and the environmental contaminants dramatically increases your risk fivefold and eightfold. So this is the kind of data that we use to demonstrate the role of environmental exposures to cancer risk, in this example, liver cancer. So there is some data on genetic susceptibility to liver cancer. We don't have the same kind of data like we have for breast cancer, where there's a couple of major genes where mutations in them lead to very high risk, like BRCA1 and BRCA2. There is very limited what we call genome-wide association studies, where people look at the DNA of individuals, cases and controls across the genome for genetic variation, mainly single base changes, single nucleotide polymorphisms across the genome. And if you look in the literature, there are a number of papers that suggest different pathways that make sense, that genetic differences in these pathways are responsible for some of the risk of liver cancer. How you metabolize the carcinogens. Oxidative stress is a major risk factor. Immune function, inflammation, cell cycle control, and what I consider one of the biggest risk factors for cancer risk is your ability to repair your DNA when it is damaged, because we know that DNA damage is a critical first step in most cancer development. And being able to repair that damage, which varies from person to person, can be a major risk factor. But there's a lot more that needs to be done in terms of genetic susceptibility to liver cancer. I'm just going to briefly turn to prevention. So hepatitis B immunization was mentioned already. This was a really impressive study done, it's a small study, but done in Alaska Native children, where you can see on the left the prevalence of the virus infection in young children, how it decreased dramatically with the use of immunization. And so there was basically no HBS positive individuals, children, after the successful vaccination. And then on the right, you can see that the incidence of liver cancer went down dramatically because of the immunization. So the most critical thing to do is immunization. in a larger study following incidents of infection in the US, you can see that the use of vaccination again dramatically decreases the risk for liver cancer development. So finally, prevention, immunization, obviously. We now have treatments for hepatitis C virus. Here in the US, they're extraordinarily expensive, so a problem for many people. You can limit your alcohol consumption, your tobacco use. You can try to limit exposure to environmental carcinogens. The switching in China from corn to rice as the population got wealthier led to a dramatic decrease in aflatoxin exposure. And you can also try to limit your exposure to polycyclic aromatic hydrocarbons, not eat so many charcoal broiled steaks. Try and limit your exposure to air pollution, which I know is a problem in India. Maintaining a healthy weight will be a good preventive method. And there are some drugs that are starting to be used for, have started to be shown to be helpful in liver cancer prevention. So vaccinations clearly are the most important factor, and probably trying to maintain a healthy weight is the second most important thing that individuals can do. And so thank you.
Thank you so much, Professor Santella, for that very insightful presentation. Our second speaker for the day is Dr. Elizabeth Zeng, who's a transplant hepatologist at the Center for Liver Disease and Transplantation at the New York Presbyterian Columbia University Irving Medical Center. She is triple board certified in transplant hepatology, gastroenterology, and internal medicine, and has expertise in liver cancer, general liver disease management, and end-stage liver disease. Her research interests include hepatocellular carcinoma, as well as healthcare disparities, particularly about liver health within the Asian American community. She is the director of the Asian Liver Health Initiative, a culturally and linguistically sensitive program focused on improving education and increasing access to specialty liver care for Asian Americans. Welcome, Dr. Zeng.
Hi, thank you so much for having me. So today I'll be talking to you about hepatocellular carcinoma, but focusing mostly on surveillance and giving you a few key updates. So just a brief outline as to what I'll be reviewing today. I'll talk about the benefits of hepatocellular carcinoma or HCC screening. Professor Santella was able to tell us how to prevent potentially liver disease and HCC, but the problem is what if you already have hepatitis B, or what if you already have cirrhosis? What do we do in terms of liver cancer then? Then I'll move on briefly to talk about hepatitis A, hepatitis B, and hepatitis C, just to share some very key updates related to liver cancer. And then I'll end with HCC screening or surveillance during the COVID-19 pandemic. So just like Dr. Santella reviewed and highlighted for us, there are many different risk factors for developing HCC. But if you look at large proportions of the population across the world, there are certain populations that are really at the highest risk of developing HCC, and therefore these are the people who really derive the most benefit from screening if we look at large proportions of the population. So if we look at the American as well as the Asian Pacific Society guidelines, we see that they say patients who have cirrhosis of any etiology are at high risk of developing hepatocellular carcinoma or HCC, and any adult with chronic hepatitis B who is also an Asian or Black man over the age of 40, an Asian woman over the age of 50, also any person with a first-degree family member with a history of HCC, and those who are also co-infected with hepatitis D virus. These are the people who have the highest risk of developing HCC if we look across the globe and in terms of large populations worldwide. And therefore, these people derive the greatest benefit from screening. When I talk about benefit, what exactly am I suggesting? So there's many studies that look at the benefits of hepatocellular carcinoma screening. And I just wanted to, in the interest of time, I'm just going to highlight one study that was done many years ago. This was a randomized controlled trial and something that we can't unfortunately do now because of the information that we have. So this group looked at 18,000 patients with hepatitis B, and they randomized them to screening. So the half of the patients got screening for HCC, and then the other half didn't get any screening for HCC. And this was the control group. And patients who were randomized to screening were found to have earlier tumor detection. So we were able to see smaller tumors at an earlier diagnosis time. And these patients were more likely to obtain curative treatment. And this ended up, we saw that the mortality was 83.2% versus 1313, which was much, much higher in terms of patients who did not get screening. And so you can see very clearly on this graph that of the patients who did not get screening in this control arm, they had a much higher cumulative mortality compared to those who underwent screening. So the benefit is that we can detect early lesions or early tumors. And because this is an early tumor, these patients have an increased rate of getting curative treatment and therefore have improved survival. Unfortunately, again, we're not able to do randomized control trials at this time because of the knowledge that we have now, and it would not be ethical to kind of randomize people to no screening whatsoever. But there has been reviews that have looked at other studies in the past. So 47 studies were included in this systematic review. It also included some Western data with over 15,000 patients with cirrhosis, so not just patients with only hepatitis B. And again, what they found was that there was a pooled rate of early detection of 70.9% in the surveillance group compared to only 29% in the non-surveillance group. And then the pooled rate of curative treatment in the surveillance group was also higher at 51.3% compared to 23.8%. And really this study showed that there was increased survival with HCC surveillance. So now that I've shown you just a little bit of the compelling data that supports HCC surveillance, how do we do it? So the American Society, as well as the Asian Pacific Society, recommends that surveillance should be done with ultrasound, although there's really no perfect modality for screening at this point. But in general practice, we typically use ultrasound with or without alpha-fetoprotein, or AFP, which is a biomarker that is detected in blood. And we screen patients who are at highest risk every 6 months. And what we found is that the addition of AFP to ultrasound has really increased sensitivity in picking up early HCCs. Now we screen every 6 months, and this is recommended because the doubling time of HCC is estimated to be around 4 to 6 months. So if there's a very, very small lesion and it doubles in size in 6 months, we should be able to catch it in the next screening interval. I just want to touch a little bit more about alpha-fetoprotein, or AFP. So this is the most validated biomarker for HCC surveillance, but it really has its limitations. So about 20 to 40% of patients with HCC can have a normal AFP. So they can have tumors that don't produce AFP, and it will always remain normal for them. But there's also 20 to 30% of patients without HCC who can have an abnormal AFP, especially if they have a lot of inflammation in the liver. We can see abnormally high levels of AFP. But in general, the higher the AFP, the more likely the diagnosis of HCC. And some studies have considered AFP to be positive if it's greater than or equal to 20. So I just want to shift gears a little bit to hepatitis A, hepatitis B, and hepatitis C, and share some key updates in liver cancer. So hepatitis A, fortunately, does not cause chronic liver disease. And so therefore, this does not increase risk of liver cancer. But I want to highlight a little bit more about hepatitis B and hepatitis C. So you may have seen some headlines or some recent articles that have shown that there's some evidence to suggest that certain medications for hepatitis B are actually associated with different HCC risks. And I just want to touch upon that in the next slide. And then in terms of hepatitis C treatment, despite treatment of hep C, and this is because we have a lot of great medications to treat hepatitis C, patients with cirrhosis continue to have high risk of HCC, and that has been shown in numerous studies as well, and I'll highlight that in 2 slides. So going back to hepatitis B, we use tenofovir and entecavir to treat hepatitis B. These are first-line antiviral treatments. These are great oral medications that are highly effective in suppressing the hepatitis B viral load. In recent years, there have been several studies that have come out from Chinese and Korean groups, and they have shown that patients who were treated with tenofovir appear to have a lower risk of developing HCC compared to those who were treated with entecavir. And so you may have seen these headlines and you may have seen these articles, but I urge you to kind of look at the data a little bit more deeply. So there are limitations to this data. So there were significantly more patients treated with entecavir than tenofovir. The trials were not even. There was also a possibility of entecavir resistance, especially if patients were previously treated with lamivudine. So these patients should not have been on entecavir potentially to begin with. And all of this is retrospective data. So we don't have anything prospective as of yet. When we look at the US data, there was a recently published study looking at veterans, and they did not find any difference in HCC risk between the use of entecavir and tenofovir. And again, in the US published a systematic review and meta-analysis that showed, again, no difference in HCC risk in patients with hepatitis B cirrhosis when comparing tenofovir versus entecavir. So bottom line is that there's a lot of current data, but these are all from observational and retrospective studies, and the data is contradictory. What we really need at this point are randomized controlled trials that could really help to answer this question. And again, just to summarize, at the bottom line is that there's really not enough evidence to support using tenofovir over entecavir with regard to HCC risk. Now, a little bit more about hepatitis C. Like Dr. Santella mentioned earlier, we have some really great medications to cure hepatitis C. And the cure of hepatitis C now is defined by sustained viral response, or SVR. And this is defined as the absence of detectable hepatitis C RNA in the blood 6 months after completion of treatment. So basically, if you had hepatitis C, you got treated, and we are no longer able to detect virus in your blood 6 months after treatment, you have achieved SVR. And when you achieve SVR, this has really been associated with really great benefits. So improvement in liver function, a decrease in fibrosis stage in the liver, and recompensation of liver disease. But since we have been treating more and more hepatitis C and curing it, what we found that is that actually patients who have baseline cirrhosis before the treatment of hepatitis C actually continue to have a high risk of HCC, regardless of improvement in liver function, and therefore they should continue surveillance. So for example, I wanted to show you a picture of a patient that we recently had. This is a patient that we recently transplanted. This is the patient's old liver, and this patient had hepatitis C cirrhosis. We treated him for hepatitis C, and that made his liver function better, but he continued obviously to have cirrhosis. And we continued to screen him for HCC because we know that even with treatment of hepatitis C, but you still have cirrhosis, your risk of HCC is still there. And so this patient, as you can see, has 2 tumors in their liver, one right here, and then another right here. And we recently transplanted him, and we're looking now at his old liver that we took out. So now I just want to shift gears a little bit to HCC screening in the time of a pandemic. So I showed you some compelling data to demonstrate benefits of HCC screening. But during this time when medical resources are really limited and the safety of our patients and medical workers are prioritized, how should the practice of HCC be adjusted? Unfortunately, obviously, there's not enough data at this point to give us really hard directions in terms of what we should be doing. But the American as well as the European societies have given us some guidance. And so they're suggesting that we can defer HCC surveillance by 2 to 3 months during times of limited radiologic capacity, such as those experienced during the COVID-19 pandemic. And they think that deferring HCC surveillance by 2 to 3 months is likely safe. Again, no great evidence to support this. And obviously, we should be avoiding HCC surveillance in patients with COVID-19 until the infection is resolved. The Asian Pacific Society has also provided guidance on this, and they're suggesting that we should prioritize surveillance of super high-risk patients of developing HCC. And they're suggesting that the super high-risk patients are those with hepatitis B or hepatitis C related cirrhosis. They also suggest that we should use biomarkers, so AFP. This may be a reasonable alternative if we're not able to use ultrasound or other type of radiology for an extended period of time. And so just to wrap up, screening for HCC in patients with cirrhosis due to any etiology in select patients with chronic hepatitis B has led to early detection of HCC and therefore improved outcomes. And that's really the benefit of HCC screening, is that we can detect the cancer much earlier. Screening for HCC therefore should be performed with ultrasound and AFP level every 6 months. Currently, there's just not enough evidence to suggest the use of tenofovir is associated with a lower risk of HCC compared to use of entecavir with patients with hepatitis B. Patients with cirrhosis prior to the treatment of hepatitis C remain at high risk of developing HCC. And despite the cure of hepatitis C, these patients should continue HCC screening. During the COVID-19 pandemic, patients who are at super high risk of developing HCC should be prioritized for screening, although the AASLD suggests, or the American Society suggests, that the screening should be deferred 2 to 3 months, or can be deferred. It might be safe to defer for 2 to 3 months. And in the absence of ultrasound and radiology access, we could potentially use serum biomarkers like AFP for screening when everything is very limited during the pandemic. Thank you very much.
Thank you, Dr. Zeng. That was a very informative presentation. Our third speaker for the day is Professor Rajesh Dixit. Professor Rajesh Dixit is currently the Director, Center for Cancer Epidemiology at Tata Memorial Center, Mumbai. He is the Principal Investigator for IR Regional Hub for Cancer Registration in Central, Eastern, and South Asia, and is responsible for establishing cancer registries in many parts of India. Professor Dixit is the principal investigator of numerous studies on gallbladder cancer, lung cancer, cervical cancer, and is currently working on establishing a cohort of 2 million individuals for a study entitled Indian Study of Adult Health. He has about 80 publications in international journals, including the Lancet Oncology, NEJM, British Journal of Cancer, and has edited and authored chapters in books, including the UICC Manual of Clinical Oncology. Welcome, Professor Dixit.
Thank you very much for the introduction. So now I think the global epidemiology, the risk factors and treatment options of the liver cancers are very well covered by the two previous speakers. So I am basically confined my talk to the India, that what is the incidence of the liver cancers in India, what is the heterogeneity in the different parts of the India, and what are the possible risk factors and what the government is planning for the prevention of the hepatocellular carcinoma in India. So if you see, this is the slide from Globocan IR, and you can see that India is not the country with a very high incidence of the liver cancer. So incidence is around 3 to 4 per 100,000 average in different parts of the India. The high incidence of the liver cancer, as we know, is in the North America, in some parts of Western Europe, even in the Latin America. And interestingly, but you know, the risk factors are different in these different parts. So even though these different regions have a different incidence rate, the risk factors are also different. For example, in India, the main risk factors remains the infections with the hepatitis B and hepatitis C virus, followed by the alcohol. So the main the risk factors in India is the infections with the viruses. While if you see, so this is if you see in the North America, the main risk factor is basically the hepatitis C and the alcohol drinking. So that's the major difference. So even if we go to the Western countries, the major risk factor is the alcohol drinking, followed by infection with the hepatitis C. But in India, if you see, the main risk factor is the hepatitis B, and the infection with hepatitis C, and then the alcohol drinking. So these are the different etiologies in India versus the Western part. And if you see the infection thing, the liver cancer overall in the developing countries, it's a 77% of the liver cancers are caused because of the infections from the hepatitis B and hepatitis C virus. So it's a very important risk factors if you want to prevent the liver cancers in India. And this is the somewhat busy slides, but this just want to show where the liver cancer in India. So if you see the disability adjusted life years, so then the 3.5% deaths are because of the liver cancers in India, and it's at number 11. So the most important thing is the breast cancer, cervical cancers, and stomach cancers. They are the most important cancers if you consider all over India, and it's 16% of the deaths are observed because of that. But for the liver cancer, it's almost 4% of the deaths are because of the liver cancer. So just to tell you this, this tells you that overall, if you see the India, it doesn't seem to be a very common cancers in India. And if you see how the risk is growing over the years, then you see in the year 1990s, the liver cancers was ranking number 15 among all other cancers, male and female combined. And now recently, it has moved to number 12, liver cancers. So of course, the breast cancer is on the top. And its age-adjusted rate changes is almost 32%. So the change in the age-adjusted rate of the liver cancer from 1990 to 2016 is almost 32%. And so this means that there is some increasing trends of the liver cancers in India, while many other cancers like cervical cancers, stomach cancers are declining, and even the esophageal cancers are declining. But some of cancers like liver cancers, the esophageal cancers, the breast cancers, they are continuously increasing in India. So it seems that the cancer pattern, the cancer epidemiology is changing in India, shifting from 1990s to 2016. And there could be many reasons for this. And if you see the different registries, these are all population-based cancer registries in India. There are 40 population-based cancer registries in India. And you see there is a huge number of differences in the age-adjusted incidence rates of the liver cancers. So the north and the northeast, particularly this Arunachal Pradesh and the Mizoram, which is in the northeast part of India, has a very high rates of the liver cancer, which is 21.4 per 100,000, 11.3 per 100,000, and even some of the northern states have around 7 to 10 per 100,000 incidence rates of the liver cancer. But the rest of the India, you see, it's between 2.5 to 3 per 100,000. And therefore, if you average it out, total Indian burden of the liver cancer is 3.6 per 100,000. But yes, there are some pockets like in the northeast or the northern parts of the India where the liver cancer is very high. And this gives you the opportunity as an epidemiologist to see that what are these reasons for this heterogeneity, and someone has to look into it, the reasons. Is the prevalence is also different in these parts of the India for the hepatitis B and hepatitis C? That could be a good questions to ask. And these are the various registries where the liver cancer is among top 5 cancers. So basically the Arunachal Pradesh, Punjab, some of the rural parts of India, it's ranked 2. It's the number 2 cancer in some of these registries. So again, to tell you that this is a very important cancers in some parts of the India, particularly the Arunachal Pradesh, Assam, Meghalaya, Punjab, and some northern part. Maybe you can go to Sikkim. This cancer is very high rates are there, and it's number 2 to number 3. Maybe you may require to do screening, particularly in the Arunachal Pradesh, where the cancer rates are almost 20 per 100,000. It is higher than cervical cancer in India. And if you see the trends among 5 registries, the big registries in India, Bangalore, Chennai, Delhi, and Mumbai, these metro cities, then you see there is slight increase, somewhat increase, but it's not increasing that like breast cancer, you could say, or colon cancer is increasing in India. You can see it's almost a parallel line, except maybe in Bangalore, it could be some under registration, I think, in the initial years. But you see, there is some increase in one city, but otherwise it's almost parallel. But nevertheless, when we compare the age-adjusted rate between 1990 to 2016, there was a 32% increase in the incidence rates of the liver cancer in the different parts of the India. And if you see the projection based on the current registry data, the projection of the number, then we expect that if nothing changed, then you will have around 30,000 male cancer cases, number of cases of liver cancer, and around 12,000 liver cancers among female. So even if the crude rate and age-adjusted rates are low, the numbers are quite high because the huge population. So you have to do something. And as it has been told, so there are the major risk factors now for the liver cancer. At least as far as India is concerned, it's chronic infection with the hepatitis B because the vaccination is not that 100% for the HPV infection. Chronic infections with the SCV is another area of the concern. Aflatoxin, there is food grains which are exposure to the aflatoxin that could be another important cause for the liver cancers. At least 20 to 25% of the liver cancers are because of the exposure to the aflatoxin. Then cholangiocarcinoma, we know that it's a liver pathology is there. And the common risk factors are like chronic alcohol consumption and non-alcoholic fatty liver diseases that could be another risk factor, at least as far as the India is concerned. So the alcohol consumption again is not very high in some parts of India, but it's very high if you go to north and the northeast of India. The alcohol consumption is very high, and that might explain probably the high rates of the liver cancers coupled with HPV infection in those areas. So if you see the prevalence of hepatitis B and hepatitis C in India, so it's almost 50% hepatitis B prevalence in India. Many of the studies, large scale, they are not cross-sectional, they're still small studies. So I have selected only the studies with 300 to 200 number study. But you see, it's not very high in the tumor tissue. It's a 54, it's a liver cancer, 54% for the hepatitis B, and almost 16% for the hepatitis C. Hepatitis C. And I think the mode of transmission of hepatitis B virus is also somewhat different in India than European countries. It's more like a horizontal transmission because of the poverty, because of the socioeconomic, low socioeconomic status, because they might be sharing their toothpaste, their belongings with the siblings. So there could be more horizontal transmission. And we don't see, there are not much evidence of the vertical transmission like you see maybe in Africa, where there's a transmission from mother to children. So that could be one thing. And of course, the hepatitis C, I think main cause of this prevalence is because of the blood transfusion. So the quality, and there has to be improvement in the blood transfusion now in the urban areas. The use of sharing of needles and sort of thing, that could be the one of the major risk factors for the hepatitis C virus infection. And if you want to see the population attributable risk for the liver cancers because of the hepatitis B and hepatitis C, and if you combine both of them, then we have estimated it. This was published in the Cancer Epidemiology in 2016. So based on the two studies, based on the global point data and based on our own million-day study data, that because of the HBV, we estimate that it's around 67% of the liver cancer are because of the hepatitis B virus, and almost 20% of the liver cancers are because of the hepatitis C viruses. And if you combine B and C, then almost 72%, 70 to 75% of the liver cancers are because of the infection from hepatitis B and hepatitis C. So it means that in India, a lot of liver cancers could be prevented if we have a good strategy for the prevention of from the infection with hepatitis B and hepatitis C infection, because this seems to be the major cause of the liver cancers. And therefore, the strategies in India has to be the vaccination for hepatitis B, which now government is planning, reducing the aflatoxin, producing the food, because there are food items which are not stored properly, and because of the moisture, there is an exposure to the aflatoxin, reduction in alcohol consumption, and proper cooking of fish, so that to reduce the possibility of the human infection from the liver fluid. So this could be the four basic strategies for the reduction or the prevention of the liver cancers in India. And therefore, the government of India has launched a national viral hepatitis control policy on 20th July 2018. So, and the major aim of this policy is to control the hepatitis and to achieve the countrywide elimination of hepatitis C by the year 2030. So that's a major goal of this policy. And then, of course, another thing is to do the continuous surveillance for the infection with hepatitis B and hepatitis C, and see the significant reduction of the infected population, and to see the reduction in mortality and morbidity associated with the hepatitis B and the hepatitis C viruses. And then third goal of this policy is to reduce the risk and morbidity and mortality due to hepatitis A and hepatitis E. This thing. So what are the implementation goal for this policy is to create the community awareness. But one of the challenges is it's always difficult to make the behavioral changes. And so that's going to be a major task. And how to provide the early diagnosis and management of viral hepatitis at all levels of healthcare. So this means that if you want to do the prevention in the rural as well as in urban areas, then not only the bigger hospitals, but even the smaller healthcare facilities should have the facilities for the early diagnosis and management of the viral hepatitis. And there has to be development of a treatment and proper diagnostic protocol, which Government of India has done now because of these facilities. And for this, you have to strengthen the existing infrastructure which is available and build the capacity for the testing of hepatitis B and hepatitis C viruses. So those challenges, as I said, that do the behavior changes, it's always challenge to how to make people aware about this liver thing, how to make them aware about the infection. And of course, the immunization coverage of the bulk doses of hepatitis B and coverage with 3 doses of hepatitis B vaccine in the infant. I think it's going to be very challenging, but let's see, let's hope for the best that it will happen in the future. And we have to ensure the safety of blood and the blood products, and of course the safe drinking water, hygiene, and sanitary toilet, which is now under the major aim of the government to provide the toilets to every small villages to possibly also help to control hepatitis B and hepatitis C viruses. And the one last slide just to talk about something about the COVID-19 infection and the hepatitis, because everyone is interested in that. So now it has been observed that in the COVID-19 patient who are severely ill, there is an increase in the SGPT and SGOT levels. That has been observed. And so, but we don't know what does this mean and what would be the long-term impact of this elevated levels of SGPT and SGOT on SCC. So I think this could be a very interesting cohort if someone is doing the surveillance of the COVID-19 individuals, to follow them up, particularly those individuals with a high level of SGPT and SGOT. And the other thing is, because the effect of immune-based therapy, what is the effect that has also to be monitored in the future, whether it affects the liver in future. So of course, that's all the long term we have to see. At this point of time, no one knows what will be the impact of COVID-19 on the liver diseases or on the hepatocellular carcinoma. Thank you very much.
Thank you, Professor Dixit, for a very interesting presentation. We will now have the question and answer session that will be moderated by our director, Dr. Ravina Agarwal. Perhaps
start with a question that is very um, that looks at a comorbidity, and it's asked by Aruna Umar for heart patients who are on a high dose of statins. What tests other than liver functioning tests, that's the LFT, are required? Is that if heart patients are on a high dose of statin, does that come in the way of taking a liver function test? Dr. Zeng, would you like to answer that?
So yeah, I typically do check the liver tests pretty frequently when somebody's on a high dose or recently started a statin. You can also check creatinine kinase levels or CK levels. That also looks for muscle breakdown for certain patients who use statins. But generally, liver tests are just fine.
Okay, all right. This is a question then for for all the panelists. But while I have you, Dr. Zeng, I know that you have answered that individually, but perhaps our audience would like to understand this altogether. So, how are liver organs allocated to patients with hepatocellular carcinoma? And I mean, I know this. We'd like to get your perspective on this, and then if Dr. Dixit would talk about the Indian perspective, and so how are these liver organs allocated, and what are some of the changes we can expect, and can we in the next several years?
Sure. So the way that organs are allocated at this point in the US is based on severity of liver disease. And so we calculate severity of liver disease by using the MELD score. And the MELD score takes certain lab values. So it looks at the liver function, it looks at the kidney function. And so the worse the liver function is, the worse the kidney function is, the higher the MELD score. And so therefore, the higher you are on the waiting list for transplant. Now, patients with liver cancer traditionally actually have low MELD scores. These are patients who usually have pretty good liver function, pretty good kidney function, but they have liver cancer. And so their MELD score doesn't truly reflect their mortality or truly how sick they are. So many years ago, the organization created exception points. So patients who have HCC can get exception points. And these exception points can push them higher on the waiting list. But every patient with HCC gets the same amount of points. So typically, they can get up to 28 exception points, which is pretty high because in New York, we transplant at around a score of 30. So if your MELD score is around 30, you can get an organ pretty easily. Based on how big the tumor is and based on how high the AFP level, so the HCC has to fulfill certain criteria. And once it fulfills certain criteria, after we wait 6 months, then those patients can get the exception points. And the reason why we have to wait 6 months across the board, this is the policy for the whole country, is because the 6 months allows us to observe what the tumor is going to do. So for some people, if they have really, really aggressive liver cancer, within 6 months, it might be, very, very big, or the AFP level might be too high for transplant. And so it allows us to observe them for 6 months and allows us to see, how they might do after transplant as well.
Dr. Dixit, could you talk to us about the process in India? Do we expect to see, modifications which systematize it further? Because there's, of course, a huge informal market. There's huge disparities in income and access to that kind of care. So do we expect to see something happening in the policy space, or do we see something in the medical space that would that you can talk to us about in terms of liver organs?
Yeah. So I think in India, I think the liver transplantation is not that yet common, and it's not that uniformly or practices are. There are, however, a few institutions in Delhi or in Hyderabad where they are very specialized institute for the liver transplantation. So I think it's still a long way to go for that, for the main treatment of the liver cancer is the liver transplantation. I think a major goal of the prevention of the liver cancer is through the vaccination. I think that's the major thing, and it is, as you know, that the government of India has that major target that every child should be vaccinated almost 90 to 100% for the hepatitis B viruses. So that's the current goal, and I think on that goal government is working.
Okay, so while we're talking about vaccination, um, you mentioned in your talk about the behavior change that's going to be needed, right? We have a lot of vaccine avoidance and mistrust and a lack of awareness of the serious consequences of hepatitis, even in hepatitis B, right, where the vaccines might be available, or C. So I want to understand from you, what do you think are the processes? Is it like education, public awareness, media awareness? Where do you think we should really, be pitching this? Is it availability or access to vaccines, A? Or is it also awareness and trust in the vaccinating body?
Yeah, I think, of course, it's any marketing thing. If you are going to advertise something, then you need that product has to be available in the market. Otherwise, there is no point in this thing. But as far as hepatitis B vaccine is concerned, I think availability is not that problem for that thing. Main thing is the awareness, and particularly the most of the deliveries, they are not institutionalized. They are not in the institution. So if in the rural areas, if the deliveries are not taking place in the hospital, then they may get away with the vaccination at the time of the birth. So that could be also one of the major reasons. But as you said, that I think major thing is creating awareness somehow, and this because there is a lot of thing that this vaccine will cause this, and you will have some problems. So there are so many misinformation is spreading everywhere. That someone who's going to get the vaccine, he think twice before going to the vaccination center. We have seen this even for the COVID, when during the first wave. So I think the creating awareness, that is the major goal. That the first thing, how to do it. There could be the different ways, advertising and other things. But of course, if you can also ensure that at birth you can give the vaccination, because that's you can't escape, because you are there, and if you can have more and more birth in the institution, then there is a possibility that we can achieve this target of getting 90% getting vaccinated. Because so far, I think as per NFHS data shows in India, only 40 to 45% are vaccinated with hepatitis B virus. So that's the current data. So we have to almost double this thing.
Yeah, your study showed like the geographical regions, the different registries in different geographies, and I noticed you didn't have it for Jammu and Kashmir. But in Ladakh, where I did a lot of my research, we do find quite high incidences in rural areas, and a very poor vaccine receptivity in those areas as well. I'm going to move on to lifestyle issues. We've talked about some of the clinical aspects. We've talked about vaccinations, and to Professor Santella, both in terms of, I'll start with the alcohol problem. Where you've talked about tobacco and alcohol consumption, or alcohol consumption being related to liver.
So if the question's related to concerns that, because in the chat there was a question that I answered about, with lockdown, people are drinking more, at least in the US, and potentially smoking more. I haven't seen more about smoking, but I have seen concerns about increased alcohol use. So yes, it is a concern. It may be hard to demonstrate an effect epidemiologically, because the effect may not be very large, and if the effect's not large, it will be hard to document. Somebody asked about a hepatitis C vaccine, but there isn't one. That's the problem.
So it's, in terms of warning labels, do we need a lot more kind of public awareness campaigns? Because we in India, for example, with tobacco use, we have a very, very, a history of very strong campaigning, and all kinds of measures, whether it's persuasive or very horrific types of imagery and very, very consistent campaigns. So do you think some kind of warning labels or, such kinds of the alcohol use also warrants this?
So in the US, we do have warning labels on alcohol, but it's primarily for pregnant women. We don't do much, as far as I'm aware, in terms of warning the general population. I mean, and alcohol is a risk factor for like breast cancer. So it is a major, it can have a major impact. So, clearly better education of the public would be useful. Not easy to do, not easy to, change people's behavior. I mean, we know that a major way of preventing cancer would be related to weight loss and exercise. Those are two things that are, that are so important, but so difficult to get people to do.
Yes. Wow. Also, I know there's a question that's very specific on the environmental causes of liver cancer. But you mentioned it, but could you elucidate that a little bit? Could you talk more about air pollution or these types of what can one do? Yeah.
Yeah, so there are a lot of epidemiologic studies looking at various environmental factors. So we've identified many. There was a specific question about the markers for exposure, the biological assays that we do looking at PAH exposure. So the specific assay that I mentioned is measuring PAHs bound to albumin. But there are lots of other studies measuring PAHs in blood, measuring PAHs in urine. We've measured PAHs on DNA in lung tissue. But those are more research assays. They're not really useful for clinical studies. There are also lots of studies that have looked at air pollution levels in different regions and tried to relate them to cancer and other diseases. I mean, it's becoming quite clear that air pollution is really, really important in terms of birth outcome, in terms of neurologic diseases and aging, as well as cancer. So not really clinical tests that will have any specific relevance to an individual. They're more for research purposes. We, for example, don't give data back when we measure PAH DNA adducts in someone because we don't know, clinically what the meaning of it is. But it's quite clear that environmental exposures do have an impact on cancer risk.
Thank you. We have run out of time, and I want to thank each of the participants for really alerting us to, whether it's, all the preventive aspects of liver cancer in countries like India or in the, other countries in the global South, where the treatment aspect is very, very, costly and requires a kind of expertise that is very specialized and not easily available. Prevention is so important, and especially when you know that it is a type of cancer that can benefit a lot from public awareness of prevention, whether it is through the vaccination process, whether it's through the screening process, or whether it's through lifestyle changes. So thank you so much for our expert panelists and all that you've shared with our audiences. I invite our audiences to please stay engaged with us. And I want you to, please join us as we continue to bring awareness on the issue of prevention and early detection of cancers for our global audiences, but also particularly for the context of India. So thank you once again, everybody, to our speakers and to our audiences. Thank you for joining.
Thank you very much.
Bye.
Bye.
Thank you. Bye-bye.